Welcome, everybody, to today's episode of Digital Health on the Air. My name is Aditya Bansod. I'm one of the founders and CTO here at Luma. Today, we're discussing the challenges of high call volumes and strategies to achieve freedom from the phone line. I'm joined today by Noreen Friel, Noreen, the Director of Operations at Luma Health, and Kat Midliler, Luma's Senior Product Manager over all things kind of call center plus. Is that a fair way of saying what you do here, Kat?
Fair way of saying yes.
And so why don't we start with our esteemed guest, Noreen? Why don't you give us a little bit of background on Mainline Health, what's top of mind for you, things that you focus on over there?
Sure. So Mainline Health, we are a healthcare system situated in suburban Philadelphia, servicing some part of Philadelphia, but primarily in the western suburbs of the Philadelphia region. So 4 large acute care hospitals, one very special Bryn Mawr Rehab. That's where I got my start at Mainline Health almost 18 years ago. And several ambulatory care sites. We centralized a lot of our service line scheduling over the past, I'd say 5 or 6 years. We're still in that process. And since COVID, all of our call center teams have been working remotely and successfully so. Not right out the gate, a lot of lessons learned, but we've been successful in transitioning folks to the remote environment.
Noreen, what a quick thing, just I've heard from a lot of folks that transition going to fully virtual. Some people tried it, succeeded. Some people tried it, didn't sucdeed. You said there were some lessons learned there. I'm sure the audience would like to hear like maybe 1 or 2 like nuggets of gold on why it worked for you guys.
Definitely monitoring. So monitoring activity. There were a lot of things that, believe it or not, some individuals were really crafty in being able to kind of fly under the radar in terms of looking like they're working and they're not really working.
I'll be the first to admit I've looked on Amazon for a little mouse jiggler to make it look like my mouse is moving, and then realize I have a full day of meetings and like.
Well, in a call center environment, like even something like that wouldn't really work because you have to be logged in and in ready status. And that is, something that has always been monitored by call centers. But, historically, I'd pop my head up and say, hey, I see like 30 people are not ready. Like there's calls waiting in queue. Let's go. Can't really do that as much, because we're not all in the same room. But, taking a look and, seeing, the length of time that someone might be in a particular status, even if they're talking for an extended period of time, like what's going on there and monitoring that call. But also really just taking a closer look at everybody's statistics and adjusting things based on that so that, short calls, something's obviously up with the phones, or somebody's manipulating something with the phones if they have, 20 or, so short calls that, there's no connection, really just making sure that everybody has the tools and resources they need to work remotely. They understand the expectations of working remotely, and then monitoring all of those expectations more and differently than we did before. We were all in one space.
That makes sense. And I think that leads us really nicely to our first question that we wanted to kind of chat about, which was high call volume. It's nothing new for healthcare, but it seems to be a major discussion point in the last year and a half, maybe. And, you have a very robust system. You guys have built a centralized call center. That was not an immediate thing that, took time and effort. So, can you talk to us a little bit more about, things that you've noticed about, how there've been more calls, the nature of what patients have needed, the changing demands of callers as they call in, and how have you managed to get over the struggle, honestly, of actually that just volume and the deluge of calls coming in?
Well, I mean, I would love to sit up here and say that, we don't have, the struggles are behind us. So we're still in the midst of a lot of the struggles in terms of call volume. So one of the major things that we did just recently, and as recently as August of last year, was we engaged with an external resource to help decant some of the calls for some cut and dry studies.
Is that a term of art in call center management, decanting the calls? Or just a fun.
I stole it from my VP, Joanna Wells.
I like it. I like it.
So she uses it, and now it's already ingrained in my head. Basically to lessen the burden on central scheduling, allowing the central scheduling team to focus on those more complicated calls, MRI, CT, nuclear medicine, perinatal testing, all the different service lines that we still have under the imaging umbrella, but taking those mammo and DEXA calls off of them, which were a lot of calls came through for mammo and DEXA. So we would take them, send them over to the sourcing partner, and it's been really successful. I will admit I was hesitant. I had a lot of concerns, letting go of the control of having that scheduling, letting go of the call recordings. However, our partner has been tremendous, and we've actually, are in further discussions about onboarding other service lines to them. So
that's super interesting. And I think kind of what you're saying there is like being able to scale up. And a lot of that has to do with the experience of the patient, the need to deliver a great experience. And Kat, you talk to not just Mainline, you talk to people across the industry and leaders across the industry. Can you tell us a little bit more about what you hear from, challenges that long hold times have on the overall patient experience?
Yeah, absolutely. No one wants to wait on hold. I think we all know that. Like that's pretty cut and dry there. So
and I think I see fancy slides here to back up what you're saying.
Perfect. Love me a fancy slide. So hold times are just, they're awful, especially when what you're doing is, you just want to get an appointment. Like you pick up the phone, you've got some free time, you just want to get an appointment. We found that in talking to people and doing research that it is just the patience, for waiting on hold is extremely minimal. Folks, 60 seconds, like that's max. And of the folks that will only wait 60 seconds, this is in healthcare specifically, of the folks that will only wait 60 seconds before hanging up, it's something like 32% of them will ever call back. So like there's lots there immediately. Yeah.
That's a crazy stat.
Yeah. So immediate patient leakage.
Yeah, that understood. And when you're speaking about, that kind of leakage, we're talking about patients that will go somewhere else because they can go somewhere else. So with our one of our largest call centers now with central scheduling, the largest service line supported by central scheduling is radiology and imaging. Someone has an order for radiology or imaging, as long as that payer, their payer, the provider is participating with their payer, they can go anywhere. When we're looking at other areas like primary care, specialty care, if they're already a patient in flight. So those are the ones where we see patients call back repeatedly. And sometimes if their ordering provider is an employed provider and they are completely dead set on coming to a Mainline Health facility for their imaging service, they will call back repeatedly. So, but that also increases the call volume, because if you have repeated callers, then it's gonna kind of give like, well, it's the same person calling back, either not utilizing the functionality of digital call deflection, of the callback feature, utilizing that, or perhaps even just going and looking and seeing if there's something that they can self-schedule online. That's one of the things we've been trying to beef up as well, to increase, access to our digital front door and getting patients to be able to schedule themselves either through a ticket, through an order that's already placed in their chart, or open scheduling, just scheduling without an order.
Right.
It's that snowball effect.
Oh, 100%. And I think this talks a little bit to, and Noreen, you're hinting at some things and projects and work that Luma and Mainline Health have done together, which was deploying some of Luma's technologies into the call center. So to kind of solve some of these problems that we've been talking about. So I'd love to kind of get maybe from Kat a little bit, just tell us a little bit of kind of the work that you had done starting, Noreen, feel free to fill in anything in here, around some of the digital call deflection and what we aim to go solve and kind of how that started to percolate into some success.
Yeah. So Mainline was the first to jump at the opportunity to utilize our product digital call deflection. I feel like we mentioned it in passing to Mainline, and then it was like, oh, let's go, let's try it. It was amazing. And then like 2 weeks later, we were live. And so we focused specifically on DEXA scans and mammos because of the low complexity of those phone calls, like you mentioned. So allowing for reducing the volume there so that the high complex and longer phone calls that really do need human to human discussion, there was more availability for those. offloading the shorter, uh, low complexity phone calls to self-service opportunities was the perfect opportunity to really try and see, what patients would opt in to self-serving themselves, and throw it at them, let them know it's available, and see what happens. And you guys have had amazing success with that.
We have. And I will tell you, even just personally, I used it myself. So I used it myself and carried it all the way through because it was that time of the year for me to have my annual mammo. And I went through the whole process and it was absolutely seamless. So it was nice to be able to actually, even, it wasn't really pretending. I was actually doing it just to see how easy it was. And not that I don't enjoy talking to call center agents, whether they're our own employed agents or those that are from our resourcing partner. Still, it was nice to be able to do that on my own.
So I have a fancy slide here that I guess they're all fancy slides with a little bit of the stats and kind of some of the numbers from the initial deployment. So let me go ahead and toss that on screen in a quick second. But one thing I'd kind of love to hear a little bit more about is sort of, that you guys at Mainline, Noreen, you have Luma's digital call deflection for Mammo and DEXA, but you also, you were saying you supplanted it with, agents who are your non-employed agents. And I think that one thing I would love to hear about is a little bit the patient feedback from that, because you just experienced as a patient, but what you're saying is you kind of need both, right? Like you digital and not digital techniques. So while I pull this slide up and so we can look at some of the results, I'd love to hear kind of what you've heard from folks in the field.
Well, patients don't realize that we're using, that we have a resourcing partner. They don't know. They're the folks and the agents on that team. They answer the phone just as if they are one of ours that are working remotely. So that feedback
that helps. That helps. It's one consistent experience.
And their key performance indicators have shown like tremendous success. I'm kind of jealous. Like our KPIs need to be a little bit more like theirs. Now, again, it's a dedicated team. That's, that team is focused solely on Mainline Health, Mammos, DEXAs. They're taking some of our MyChart help desk calls now, because we just onboarded that group. But that's it. That's their sole focus. As far as the digital call deflection, we did have some feedback from a patient recently and just took a look at everything just to make sure everything was up to snuff. She was a patient that called in, press 1 for Mammo, and then upon going through the questions, she got the text message, went in and was about to self-schedule, but based on the answers to her questions, she had to call back in. So she could not utilize that service. And that does happen. And it gave us an opportunity to call her and explain why, because she had asked for some additional verbiage in our online scheduling. And we explained why we wouldn't say that it's just for screening mammos, because it's not. There is the ability to schedule a diagnostic mammo based on some of the answers to the questions, and the answers to her answers to the questions. It was a completely different type of mammogram that she could not schedule. It wasn't a screening. It wasn't a diagnostic. It was another type. So, but
Noreen, I think this may be actually an interesting point or a lesson learned for other folks who are listening to Digital Health on Air, which is on optimization, right? Like, the first attempt is, first time to anything, like we hit a bar, and you were saying like you measure your KPIs very regularly. So I'd love to hear a little bit more maybe about how you've been optimizing a lot of this stuff and kind of changes that you've seen and lessons you might have learned over, deploying this, this, Kat, you can speak to this more, but like, I think we deployed with Mainline in April of last year.
April.
Yeah. And so
we just had a birthday.
Exactly. So, you've learned stuff over this time. Like what would you have done differently? What could you have done better? What are you looking to kind of evolve with as you kind of look to digitize maybe even more parts of the call centers to manage call volumes?
I wouldn't do anything differently, honestly. And this was the first time, obviously, utilizing something like this. So I don't know what we would have done differently. The implementation and like the ramp up was so smooth. It was fast. We really didn't mess around with a lot. We kept it simple, and we had to our telecom department had to separate out that prompt, because the prompt initially was for Mammo and DEXA. So there was some technical adjustments that needed to be made. But as soon as we did that, we had the prompt, the phone menu recordings done, implemented, and and everything was set up, and off we went. So I don't think I would do anything different with that. We did, we took a look at every single aspect of it. We had already had self-scheduling in place, so that was obviously like a good thing. So it was really just kind of plugging everything in and making sure, and that had already been rolled out. So we were already kicking the tires on that and making the appropriate adjustments, because we didn't want people to only be able to schedule screening memos. We, based on answers to questions, we wanted them to also be able to go in and schedule a diagnostic into a designated diagnostic slot and not have to come all the way out and pick up the phone. So there was a lot of integral pieces of that from our analyst team on the Epic side who made that happen too.
That's awesome. I mean, go ahead, Kat, go ahead.
I just was going to say, I think that's the main part of like learning as we go with these sort of test and learn options, is that there's always adjustments. Like scheduling is a unique beast. Patients are all unique, and figuring out how to make sure we get the patient to the right workflow, to the right person, to the right solution, so that it's not a dead end and that they don't have to restart it, is key, because that's patient experience. We want to make sure that we're providing the best patient experience, and setting expectations for what you can schedule, setting expectations for just anything about, like, for example, that this is a text message, not an email or something. Making sure that we're really learning from that feedback from your patients, and so that we can adjust and learn and make sure that we set up front what they can do and when, so they don't have to go back, because that's not a patient experience that I know I'd want to experience. So
right, exactly. How frustrating is it when you get like looped around something? It just takes me back to the main menu.
Well, I think that's one of the things that I wanted to hear. Maybe, Kat, like, you work across the industry, across health systems, which is, the distinct needs of patients. Like, some want the digital option. And, I think one of the funny things we've learned at Luma over the years is it actually doesn't really have a clear-cut answer against demographics. Like, there's the 85-year-old grandpa who just never wants to talk to somebody and would do everything online. There's a 22-year-old who's never used healthcare before, needs to talk and be, like, coached for their first major healthcare experience. And so, like, Kat, I'd love to hear kind of like what you hear about the different needs of different patient cohorts, kind of like more about like unique needs of patients.
Yeah, absolutely. There's definitely identifiers or sort of maybe programmatic things that live within certain patients in certain health systems. Some health systems have like a VIP program, or they participate in Medicare programs. And some of those things really define what and where that caller should go, what that patient should get, and figuring out how to make sure that someone who should always speak to a nurse case manager, for example, and not be sent down a self-scheduling rabbit hole because they've got this nurse case manager that is there for them. That's ideal, obviously, right? Like, we want to make sure that the patients that are supposed to be getting that one-to-one human connection and relationship and hand-holding and guidance get there, while the others that are like, no, I really just don't want to talk to a human today, don't have to. It's all these different workflows that are filtering down from each individual unique patient. And everyone wants to do that, because every patient is unique, every health system is unique. And we all are trying to answer the same thing. And in Luma, we're trying to figure out how to make sure we can help do that, how to make sure we can figure out that that caller gets to the right person at the right time, or that right text message, that right tool, that right thing at the right time, so that we can free up resources or provide the best actual human resources that are necessary for that specific patient.
Perfect. Love it. And so we're kind of coming up on the end of our little digital health on air segment today. And I'd love to kind of close with the idea that we started with, which is, being able to get freedom from the phone line, right? We have digital pathways, we have digital techniques, but we still need to enable them. Noreen, when you're kind of thinking about, work that you guys have done in mainline, you've scaled up using, augmented staff, and scaled up using digital technologies. Can you just kind of like bring us home with a little bit about, what you see as kind of the future of how digital technologies can help free up the phone line?
Well, I think that, with tools like this and being able to, looking at other areas where digital call deflection can be utilized and to get, like you said, those folks that want to utilize that type of service versus talking to someone, having both available, having both readily available, having both work seamlessly, having both provide a positive patient experience, a superior patient experience. I think that is going to be the key, because you can't just keep upstaffing and pulling people in, and it's not even just a matter of having enough people to answer the phones. It's about the quality of the individuals and the quality of their work. So and retaining them, because people are going to come and go. Digital services, they're there, and at the rate we're going, they're only going to be enhanced. They're only going to get better. So I think that keeping in mind that to both of your points, if somebody really wants to talk to somebody, regardless of their age, regardless of their demographic, that person is going to be available to talk to. If somebody doesn't want to speak to a person and wants to only utilize digital technology to get their needs met, that they have that available, obviously within those parameters. The other thing I want to mention is that kind of collecting the data, like that was something that we wanted to be able to have a little bit more automation to it. I mean, I'm not a techie person, so however that can be done to be able to show what the information you had on the slide as far as how many calls were digitally deflected. How can we really make a firm grasp on how many of those calls that were deflected turned into actual appointments? Yeah. So that was the only thing that I would say that the only thing on my wish list for this at the moment. Everything else has been a dream. So,
Kat, what about from your perspective? What's the future of kind of making the phone line a superpower for health systems?
Phones aren't going away. Phone calls are not going away. As much as we would love, some of us, for that to happen, it's not going to happen. They're here to stay. So I think, really focusing in on providing the experience, that digital experience, the right digital experience, and phone experience, the right phone experience for that patient is our primary responsibility, in making sure that patients get the care that they need when they need it via the channel they need it. And that's where we need to go. That's what's next.
It's awesome. It's an exciting future. And we're getting to see a preview of how that future involves that mainline. So Kat, Noreen, thank you so much for spending a little time with us today at this edition of Digital Health on Air. Great to hear the stories. Great to hear kind of like things that went well, things that we could get better at, things that are changing the way that patients engage with healthcare. And with that, thanks all the audience for joining us for this episode. We'll see you again soon.
Thank you.
Thank you.
Take care.